in every 2 weeks to perform screening for those 4 complications that I have just already mentioned. And those are the main ultrasound features of twin-to-twin transfusion syndrome. You're seeing one baby that is swimming in an excessive amniotic fluid, which is described and defined as polyhydramnios, whereas the other one does not have a fluid. It's so-called stuck twin, or the fluid is very little. And this is the description of twin-to-twin transfusion syndrome, sequence of polyhydramnios and oligohydramnios. The video underneath is characterized by the presence of 2 babies, and one baby is a normally growing twin, and the other one is smaller. But a definition for smaller means that the size of this baby is at about 25% less than the size of the normally growing twin. Now, how do you define polyhydramnios and oligohydramnios in twin pregnancies? As you have heard in the morning, Aris explaining about the importance of an amniotic fluid. We measure maximum vertical pocket in the sac of that twin, and throughout the gestation, there is differences in definition. For example, if we see those twins that we said that we're going to see them at about 16 weeks of gestation, and we measure that the deepest vertical pocket is more than 6 centimeters, that meets the criteria for polyhydramnios. If we see them between 18 and 19 weeks, the maximum, the deepest vertical pocket should be more than 8 centimeters, and if we see them after 20 weeks, polyhydramnios is defined more than 10 centimeters. Where for oligohydramnios, we need to have a maximum vertical pocket of 2 centimeters to meet the criteria, or sometimes we are not able to see any fluid and we describe it as a stuck twin. But what is the presence of twin-to-twin transfusion syndrome in between all the gestation? Well, this is a complication that occurs mainly between 16 to 26 weeks of gestation, and less so early and late, before 16 and after 26 weeks of gestation. Now, what about monoamniotic twins? Remember, monoamniotic twins are sharing one placenta and one amniotic cavity, and therefore we don't know which twin is producing more fluid and which twin is a stuck twin, because we have only one amniotic cavity, and in monoamniotic twins we are meeting the same criteria. Throughout the different gestation, we need to measure the maximum deepest vertical pocket, more than 6, more than 8, and more than 10 centimeters, to define as polyhydramnios. And remember, the 2 fetuses in a monoamniotic pair, they will occupy the same amniotic cavity. What we need to look for is to see the 2 bladders of the 2 fetuses, and remember, in twin-to-twin transfusion syndrome, the baby that has hypervolemia and polyuria has very extended, very thick and very big bladder that it's producing quite a lot of urine, creating the polyhydramnios. Now, in relation to the management options in monoamniotic twins, I'll go back to this later, but it's very rare to have twin-to-twin transfusion syndrome or selective fetal growth restriction in a monoamniotic pair, and it comes from the nature of these twins. Usually, the 2 umbilical cords are very close to each other, and therefore it is unlikely, or it is less than 10% to develop these conditions. Of course, we need to assess the Dopplers in monoamniotic twins, but remember, cord entanglement is present as early in the first trimester, and sometimes, just because of that, we could have a strange waveform when we are measuring the umbilical artery. is called umbilical cord notching. And this is associated with cord compression and entanglement, and it is due to acute inter-twin transfusion. It is not associated with fetal distress because if we wait and we measure it again, it will occur normal. So we need to bear in mind if we see this waveform not to get stressed and not to make any decisions about the pregnancy outcome. Now, when we are talking about twin-to-twin transfusion syndrome, we need to know the ultrasound features that are distinguishing the 4 stages of this condition. In stage 1, we have the discrepancy in amniotic fluid, polyhydramnios in the sac of one twin and oligohydramnios in the sac of the other twin. The twin that is with polyhydramnios, we call it the recipient, and the twin that is with oligohydramnios, we call it donor. When we are assessing the fetal bladders, we are seeing 2 visible bladders, and this defines stage 1. The progression of the disease appears when we see the discrepancy in fluid, polyhydramnios and oligohydramnios, but in stage 2, we are not able to see the bladder of the donor. And therefore, we investigate the Doppler assessment. We make sure that we can assess the umbilical artery, ductus venosus, and mid-cerebral artery. And if there is an abnormal flow in between the 2 fetuses, the condition has progressed to stage 3. And it's characterized by reversed or absent end-diastolic flow in the umbilical artery or in ductus venosus in the recipient twin mainly. Stage 4 identify fetus that fulfill the criteria of hydrops, which means that in 2 of the cavities of the fetus there is accumulation of fluid. It could be pericardial effusion, it could be ascites, it could be skull or head edema. Unfortunately, stage 5 is characterized by the death of 1 of all 2 fetuses. Now, it's a dramatic condition. Can we do something? And the answer is yes. And how comes? What has been established so far? I will bring you back in the early 90s. This was the era where my teacher, Professor Nicolaides, has described by ultrasound the appearance of the nuchal translucency. And not only, at this stage, he wanted to try to go into the uterus with the fetoscope and see if he can operate or make a cessation of